we're going to go ahead and get started, and the reason is we started looking, at practice case number 1, which is not in your handouts. This is just for us to talk about. In particular, this was to bring together the manual and the database so you knew how they worked together. And our example is, and many of you were in the room when we went through this previously, so this was for the folks who didn't make it back in before the second break. We have multiple masses suspicious for neoplasm, possibly plasmacytomas, and the pathology report shows a biopsy of the pharynx with plasmacytoma. FISH, fluorescent in situ hybridization on tissue from pharynx, showed an IG clonal rearrangement with a diagnosis of plasmacytoma. And what we want to do is determine the primary site and the histology. Okay? So we're going to go to the database and look up plasmacytoma. And when you see plasmacytoma, it says go to module 2, rule PH3, and that's when you have to open the manual and use the manual. Because it says here, go to this module and look at this rule. So we're going to go to the module. And we go to module 2, which is the plasma cell neoplasms. Remember it said plasmacytoma? And our biopsy was of the pharynx, right? And it said go to rule PH, did it say 2 or 3? 3. And PH3 says code the primary site to the site of origin. And our site of origin was pharynx. Okay? And it also tells us to code our histology to extramedullary or extraosseous plasmacytoma. So this is how you know which site to choose and which histology to choose outside of the database. So then you can go back into the database and look at this and see this is where it says primary site NA, see abstract or notes on module 2. So it gives you all those different references. Okay. Does that help put it together? I think we have another one here. So here's our answer. Case number 2, we have a mass in the upper outer right breast, suspicious for neoplasm. They did a core needle biopsy that says lymphoma, which is pretty generic, right? And the mastectomy shows a lymphoma, possibly marginal zone, with an immunohistochemistry that shows a translocation of chromosome 14 and 18 on the Q32 and 21 were translocated. And the impression is marginal zone lymphoma. So again, we want to look at the primary site and histology. So here we have, why don't we just look this up? Oops. T14, I don't know if I can copy this or not. So let's see if this translocation is in here. So results are 0. So this translocation didn't help us this time. So it's possible that eventually this will have a specific code for this translocation in the future if they decide that it's something that is diagnostic or pertinent. So let's go back to our case where our diagnosis is what? Why isn't it just lymphoma? Because lymphoma by itself is just NOS. It's not specific. And a marginal zone is a specific type of lymphoma. Okay? And what's the primary site? Remember, we're teaching you to use the tools. So what we need to look up is marginal zone. So don't guess. Use a database. So for marginal zone, we're coding primary site and histology, right? Primary site says NAC abstract notes on module 7. There's not a module rule, but there are some notes about coding the primary site. So let's go to Module 7. Here's Module 7. There should be some notes here. Well, there's actually a lot of different notes. So basically, these are saying code to the primary site to the organ when the lymphoma is present only in one organ. So we're looking at pH 33, which would actually give us a more direct, the module note could say CPH 33, which would be more helpful. But it's telling us that we would code this to breast. And then for marginal zone lymphoma, is it nodal? Is it extranodal? Is it splenic? It's extranodal. Right. Also called MALT lymphoma. Okay? So you may see that abbreviated different ways. Now let's go back to the case. Now, the mastectomy, the first reading by the pathologist through the microscope says lymphoma, possibly marginal zone. But the immunohistochemistry confirms the diagnosis and says it is a marginal zone lymphoma. So there is no reference to that possible. Okay? So we have a confirmation. And we have an immunohistochemistry that confirmed it. So that diagnostic confirmation code would now be a 3 and not just a biopsy, because this immunochemistry confirmed it was a marginal zone. Okay? So that's how those go together. And there's the answer. We already talked about the obsolete codes. Don't use them. Search tips. There are different ways to search, and we've already kind of gone through this, easy searches. Don't search on B cell or T cell. You'll get way too many hits. So, do the terms that look unique. A unique term is usually unique to a diagnosis. So that's the best way to look for that search. Genetic abnormalities, remember we tried to look on this translocation. Some of them are present mostly for the myeloid tumors. For the lymphomas, most of them aren't there yet. Okay? So if you're looking for these translocations, most of them will be the myeloid leukemias. And the reason that they're important is when you also look at this other part of the alphabet soup, RBM15, MKL5, I'm not going to try and tell you what those represent, but those are tumor markers. They're molecular tests. So here we have a combination of a genetic test with a molecular marker. Okay, so we have both that could search, that could confirm this disease. And that's why it becomes confusing, because the alphabet soup, you don't know if it's genes or if it's molecular tests or what it is and what all these letters and numbers might mean. So entering them exactly the way they are will help you do the searches. We already talked about this case now. Do we know how to code this yet? Do we know what condition this is? Is it myeloproliferative, polycythemia vera? Do we know? Still don't know yet. Okay? But we know now that we can use the tools and look in the database for some clues, right? Okay. So that's what we're going to do. First, we're going to look at myeloproliferative. And for myeloproliferative, myelodysplastic, we're going to look at this because it's unclassifiable the way that is written, right? So we know that these are all NOS terms. So we really want a more definitive diagnosis if we have it, right? Now remember when we looked up polycythemia vera, it had a specific code, a specific diagnosis. Essential thrombocythemia had a specific code and a specific diagnosis, right? And so did primary myelofibrosis. Now, are any of those confirmed with the information that we have available on this case? No. So the best we can do is use this NOS code. So it's myeloproliferative myelodysplastic. Okay? Because there was no further testing to define a better condition. And I'm going to talk about that process next, okay, of how you go about making and establishing that diagnosis. And there's the answer, and you have the answers in your notes also. So we're going to talk about understanding complex disease processes, the disease definitions, the clinical workup, which is really important for understanding this, and then confirming the diagnosis, which we've already kind of led into a little bit. And then we'll talk about progression and or transformation. So in a clinical workup, you need to know a little bit about the disease definition. It's in the database, right? So it also helps to look at risk factors and signs and symptoms. And when I talk later in the latter part of our presentation, we're going to talk about myeloid neoplasms and lymphoid neoplasms, and we're going to go through risk factors and signs and symptoms, okay? And then for the diagnostic workup, look at all this stuff that can be done. So what's done first? A clinical evaluation. Patient comes in, says, I feel horrible, I'm fatigued, I got this bruise, these bruises. So they do a clinical evaluation. They usually will start with the CBC, right? A complete blood count. Basic, simple. Let's see if this person's anemic or, there's something else going on. Part of that clinical evaluation is also a history and physical, because they want to know, were you exposed to certain viruses, because some of them are viral related. How long have these symptoms been going on? Different things like that. Do you have a family history of a certain type of disease? Those things. Now, we're going to talk about CBC and what's normal and what's not. But this is kind of the order that these tests go. And the further down you go, the more specific the diagnosis becomes. And a specific diagnosis with molecular cytogenetics, the genetic testing with the specific translocation of the genes, you can't get much more specific than that. Okay? So this is a disease definition for primary myelofibrosis. And notice that I'm using these terms that don't sound like leukemia or lymphoma. This is a proposed criteria for primary myelofibrosis. There are major criteria, there are minor criteria, and each condition has this type of a definition. You don't need to know that, but by reading the disease definition, it'll give you clues of what to look for in the medical record. Here again, alternate names and the definitions. Primary myelofibrosis is a disorder, blah, blah, blah. So let's just look it up. What does primary mean? Primary or secondary? Primary myelofibrosis means the myelofibrosis is not a result of something else that caused it. So it's not a secondary condition. It's a primary condition. If you have secondary thrombocythemia or secondary myelofibrosis, that's not a malignant disorder. It's a reaction, the body's immune reaction to that other factor that's causing the disease. And once you correct the cause, the myelofibrosis goes away. But if there's no cause for the myelofibrosis, they call it primary. And then it is a malignant because it's a clonal condition. So when we look at primary myelofibrosis, here's our disease definition. Disorder of the bone marrow in which the marrow is replaced, I can't read it very well, by fibrous tissue. Clonal myeloproliferative disease, which is characterized by a proliferation of mainly megakaryocytic and granulocytic elements. And see, I've already lost everybody because of the words, right? It just starts to sound like a bunch of big words again. But that definition is there. Sometimes you might need to read it a couple times. But notice that there's always the abstract or notes right below it. And these tell you what to look for. Primary myelofibrosis, rare bone marrow disorder, and it tells you what to look for, disease in the spleen, blah, blah, blah. So that is how you use that. Is it starting to come together a little bit? Okay. So, here it is right here where I can read it. So here's the disease definition, and then the abstractor notes, and the diagnostic methods. Now look at this diagnostic method for primary myelofibrosis. It's clinical. What does that mean? Well, that means you're not going to get a genetic study. You're not going to get a tumor marker or a molecular marker of any kind. Basically, we have a couple types of conditions going on. And diagnoses can be diagnoses of inclusion or exclusion. And a diagnosis of inclusion is like our first example. Probable myeloproliferative neoplasm that could include polycythemia vera or essential thrombocythemia. So these are inclusion. Exclusion would be, I have ruled out polycythemia vera, I have ruled out primary myelofibrosis, and my diagnosis is essential thrombocythemia. So that's a rule out, or diagnosis of exclusion, because they've ruled out the other things. So you take A and B and C out, so it has to be D. And this is my graphic of what this diagnostic workup looks like. It's the same basic list as the one we saw before, but here we have clinical evaluation, history and physical, CBC, that's all really generic. And as you go down these tests, it hones down into a diagnosis. So it filters down until it gets a confirmation. That's why you can see so many terms in a single medical record for one condition, because they're ruling out all these other things until they get the exact diagnosis. In the history and physical, you're going to look for viral exposures. Herpes virus is associated with a number of neoplasms. EBV, or Epstein-Barr virus. The Epstein-Barr virus is associated directly with Hodgkin lymphoma. EBV is mononucleosis, is the cause of mononucleosis. And about 98% of patients with Hodgkin lymphoma are EBV positive. And that percent changes somewhat when you add in the HIV positives, because HIV is also a viral exposure that puts a person at risk of developing Hodgkin lymphoma. And they have very aggressive Hodgkin lymphomas. If you have a combination of EBV and HIV, it more than doubles your risk. So this combination, this compounding effect of viruses can be very detrimental. And the interesting thing about viruses that a lot of folks don't really understand is viruses aren't like bacteria. Bacteria, when you have bacteria in your body starts an immune response, or you might need to have antibiotics, right? Viruses, and then they're gone. You can test your body and you might find antibodies, but there will be no more bacteria. It's killed. Viruses, on the other hand, always hang around, which is why folks who have chickenpox, when they're in their late life, get shingles, because it's the same thing. The virus never went away. So all these viral exposures mount up. And as a person has more and more viral exposures, they're more at risk of developing lots of different types of diseases, including malignancies. Viruses are pretty nasty. HTLV1 is a virus that not a whole lot of folks are familiar with. It's also called HIV-1, but it's not the HIV that causes AIDS. This one causes leukemia, a specific type of leukemia. HTLV1 is another virus that can be transmitted just like HIV or hepatitis or herpes or anything like that. It is common in developing countries. We get a great deal of our blood supply, believe it or not, from Brazil. Or the blood that we get from Brazil has a higher rate of HTLV1 than does in the United States. So we we check our blood for hepatitis, for HIV-1, for HIV-2, for HIV-3, and for a lot of other conditions. I did a talk in Florida last year, I think, and I scared the heebie-jeebies out of everybody. They were scared to touch anything when I was done. So it was kind of funny, but it was to take home that message that viruses are turning out to be a source of causation for a lot of these conditions, especially the immune modulating diseases. Infections, chronic and acute infections, especially if they are chronic, they're consistent. Your body's immune system is continually firing, and at some point in time, the immune system might not shut off, and it might start to proliferate, and then you have a tendency to go in. So when they're doing the H&P, they want to look at these things: environmental exposures, chemicals, pesticides, all that junk. So for leukemia, they're going to start out with the CBC and usually a peripheral smear after the CBC. Then they look for molecular tumor markers. Then they do a bone marrow. Then they immunophenotype with one or more of the following. They do karyotyping and they do molecular genetics, unless they have a diagnosis earlier. If they can get a diagnosis from the bone marrow, they'll take that diagnosis from the bone marrow. I shouldn't walk away from the mic, sorry. Take it with, oh yeah, I can do that. For lymphoma, we don't start with the CBC because the lymphoma is not going to show up on the complete blood count. It's usually, remember, lymphomas usually are collecting into kind of a solid, squishy kind of tumor. It's in between a solid and a liquid. So they do a tissue biopsy of a lymph node, of an organ, of the skin. We have lymphomas of the skin. And then we want to do the immunophenotyping to find out if it's a B cell or a T cell. And then we want to do the molecular and cytogenetic testing to see what type of lymphoma it is to again, hone it down, just like the diagram showed. Now, the imaging studies are also a requirement for lymphomas, so you must look for them when you're abstracting cases. It's not required for the diagnosis, but it is for staging. To do complete staging for any lymphoma, not only do they have to do the biopsy and find out what kind of lymphoma it is, but they need to do what usually ends up being a PET scan these days to see what other nodal areas are involved so they can stage it. Okay? We'll talk about staging at the very end. This is a normal blood count. It varies a little bit from institution to institution, but these are generic values, normals. The nice thing about reports today is, they show whether they're high or low, so you see them pretty easily. When they're looking at an abnormal blood count, though, we're looking to see how many cell lines are affected. Why? Because we're looking for a clonal abnormality. Okay? Are the eosinophils haywire? Are the megakaryocytes going haywire? Are the plasma cells out of whack? So that's why we're looking at the cell line. We're looking for a clonal aberration. And which direction? Is it too many or too few? Because if it's too few, you want to find out where that imbalance is. Is it just too few or is it too many of something else? And how long has it been going on? And this is why it becomes important to rule out all these other conditions. You can have abnormal CBC for lots of reasons. Some of them could be myelodysplastic syndromes or leukemia or lymphoma. Some of them are not. So you can't just say abnormal CBC, this person has cancer. So this is what a peripheral smear looks like. Blood, tissue, bone marrow, special stains. This is a reticulin stain. And then immunophenotyping is where we are trying to determine what the cell line derivation is and what's proliferating and where it's differentiated. So at what point in that hematopoiesis diagram is the abnormality taking place? Okay? And again, is it too much or too few? When you see the term like CD4, CD8, CD32, CD474, I think there are like 400 of them now. These are called cluster designations. I don't know my way around cluster designations. but there are certain combinations of cluster designations that will establish a diagnosis of certain types of leukemias or lymphomas, not leukemias. So you'll only see the CDs in the lymphomas because it has to do with the white blood cells. But it can be diagnostic. And the immunophenotyping, again, are the usual IHC, FISH, flow cytometry. And here again is our alphabet soup. These are tumor markers. These are the conditions, abbreviated: chronic myeloid leukemia, polycythemia vera, primary fibrosis, essential thrombocythemia. But these over here are the markers. And for CML, it's actually BCR-ABL1. It's the Philadelphia chromosome, which is named after the place where it was discovered, the Fox Chase Cancer Center in Philadelphia. And what happens is these two parts of chromosomes switch places, and they create the Philadelphia chromosome. PDGFRA, PDGFRB, and FGFR1 are certain types of, they are a brand new classification of neoplasms because of this new molecular testing, and they look for specific markers there. Notice here, you all familiar with JAK2? You probably heard of JAK2, right? JAK2 is an interesting little test because there are actually at least two JAK2 tests that are commonly available right now. JAK2 in polycythemia vera on exon 12. Some of them look at exon 12, and some of them look at exon 16, I think, but you don't need to know that. Polycythemia vera can be confirmed by looking at JAK2 because about 90-something% of polycythemia veras are JAK2 positive. These other myelodysplastic syndromes are JAK2 positive, but in the lower percent, so it's not diagnostic. But if you have JAK2 and MPL-W151LK, you know, and what does all that stuff mean? You don't need to know. I don't need to know because I'll never remember it. But you will eventually remember some of them. KIT is something that you may see frequently, but it's kind of generic. JAK2 is proving to be a little bit more generic. But BCR-ABL1 is diagnostic of CML. And the best thing about the identification of BCR-ABL1 is there is, since 1990, a new class of drugs called tyrosine kinase inhibitors that are incredibly effective against these leukemias. And there's a second generation of them now. The first ones were called Gleevec. Most people have heard of Gleevec. It's a breakthrough drug, really a breakthrough drug. It's also called, the actual drug name is imatinib. So if you look in SEER-RX, you can look up Gleevec or imatinib and find them. Okay. All of them end with inib. The second generation of TKIs are dasatinib and nilotinib. Obviously, I'm not a medical oncologist. So for CML and ALL, treatment with a chemotherapy. Okay, Bertie. Treatment with chemotherapy, a standard chemo regimen, plus these new TKIs is highly effective for inducing remission. It's not so effective for cure. And the reason is, in order to cure these leukemias that are based on a genetic abnormality, you have to kill every single one of those cells. Every one of them in the body. If you have one left, that's enough to repopulate that leukemia and make it start over again. And what's the only way to do that? Bone marrow transplant. Sometimes it takes two because one cell might be left after the bone marrow transplant. So that's where this really takes an interesting turn looking at these genetic abnormalities, because if we can find out how to correct a genetic abnormality somehow, which is on the horizon, we can directly treat these cancers and be extremely effective in curing the disease, not just treating the disease. So we're making huge steps here. And then molecular cytogenetics, just to give you some idea, I was going to put in a bunch of slides about genetic stuff, and I thought, no, you guys are going to get enough here. So you can have single chromosome mutations, double chromosome mutations, and they can be, the singles can be deletion, part of the chromosome gets cut off, so it starts reproducing abnormal broken chromosomes in the cells. Inversion, so they can switch. Duplication, so you have 2 copies of a gene instead of 1. Or they can be rearranged. If there are 2 chromosome mutations, that's when you have the translocation like the BCR-ABL. And I may have a picture of BCR-ABL in here, but I might have taken it out. This is where we are a lot of times as registrars, right? And those aren't the streets of San Francisco, even though if you've been walking or driving, you'll see that that's similar. But when we're looking at which diagnosis is correct, we have to really look at the provisional diagnoses, the final diagnoses. Frequently, these go to experts for consultation because you might not have a lymphoma or a myeloid neoplasm expert on staff. So they send them to AFIP, or there are certain hospital-based pathologists that are experts as well. And then you can get that appended diagnosis. Why is that sometimes problematic? Well, if you're dealing with paper medical records or electronic medical records, that late filing, it's a bear. And a lot of times that appended path report or amended diagnosis doesn't make it in the chart for a long time. So it can be difficult. Sometimes you have to go look for it. If it says sent out for consultation, you got to go look for it. We already talked about the diagnostic confirmation codes, and especially that code 3 we talked about. The instructions that go with it, which are the second page of that handout, are very important, and I'd like you to reference those as you can. They have also appear in the Fords and the SEER manual and in most state manuals if you have a state manual. Now let's talk about disease progression. Progression of disease means the disease keeps getting worse. It starts at one point when they're diagnosed and then continues to get worse, with or without treatment. You know, sometimes with treatment they continue to progress. Sometimes without treatment they follow them, so they're doing watchful waiting treatment. Remember, no, treatment is treatment. And the stage just keeps getting worse. Or in the instance of, for example, plasmacytoma, which is a disease of the plasma cells, we use it as one of our examples. Plasmacytoma frequently will start out as a single site, and a lot of times it'll involve the spine, and it'll be a spinal plasmacytoma. If it's one, it's solitary. Even if you have 2, they'll call it solitary. They won't call it plasma cell myeloma yet. It has to meet a certain diagnostic threshold of disease burden, how much disease is in the body, before it meets the criteria for being a plasma cell myeloma. But that's progression from solitary to disseminated disease. Full-blown multiple myeloma has blastic, like punched-out lesions in the bone. If you see like a X-ray of a head, it looks like there's holes punched in it, which is different than the kind of bone mets that somebody gets from breast cancer or prostate cancer. They look completely different on imaging. So it's a punched-out lesion is what they call it. And they're treated very differently. However, most folks who are diagnosed with a plasmacytoma within 10 years will develop multiple myeloma or plasma cell myeloma. So it is a progressive disease that they are trying to identify new methods for treating early stage disease so it doesn't have that progression. Solid tumor disease progression is very similar to that. You know, it extends beyond the organ of origin, involves the lymph nodes, involves the body cavities, and then involves distant metastasis. So lymphomas kind of do that. Leukemias, on the other hand, start out spread throughout the body because you have that clonal proliferation of abnormal cells circulating all through your body and reproducing in the bone marrow. So it's already distant stage 4 at the beginning. And that's for all leukemias. When we're looking at progression, we have changes in symptoms. Symptoms get worse. The treatment can change. It can become more aggressive. And the prognosis and life expectancy gets worse as disease progresses. But the malignancy involves the same cells, cell type, the same genetics. Nothing changes in what's wrong with the cells that are involved. And we talked about that already. It has the same cell type, the same function, the same genetics. A transformation, on the other hand, the cells actually change. Okay? The nature or function or condition changes, and the cells undergo an additional genetic abnormality. So there's a second malignant transformation. And that's why these become new primaries, because they are not involving the same clonal line of cells, and there's a different genetic mutation. All of your transformations will be in the myeloids. There are no lymphoid transformations. There's only progression. And most of them go from a myelodysplastic condition like chronic myeloid leukemia or polycythemia vera to acute myeloid leukemia. That's the typical progression. And treatment obviously changes. Treatment for polycythemia vera is, they might do a phlebotomy to reduce some of the overproduction of cells, so to get the body back in balance again. They could treat with aspirin, but you don't code it as treatment. You only code treatment with aspirin for one condition, and that's in the CRX. And that condition is essential thrombocythemia. You can look up aspirin in the CRX, and it will tell you that too. And survival is incredibly different once a transformation has occurred. Usually when a condition transforms and goes from a chronic condition to an acute condition, if untreated, it's usually fatal, sometimes in a week, sometimes in a couple months. But it's rapidly progressive. The genetic mutation just explodes and has to be treated immediately. So here we're looking at case number 1 again. Oh no, we already did this one. We already did that one. That was just to confirm that, we added the JAK2 negative there. So if it was JAK2 negative, these 3 conditions were in our differential diagnosis, right? And it's JAK2 negative. Again, that leaves us with that NOS, myeloproliferative NOS, because all of them are JAK2 negative. That's why we added that JAK2 part in there. So, okay, back to the tools and rules. We are going to talk about the classification of tumors. I'm going to talk a little bit about those groups of neoplasms that are in the WHO, the 6 groups of myeloids and the 6 groups of lymphoids. We're going to talk a little bit more about the rules and manual. So like I said, we keep coming back to different things. I am not going to go through all of those rules because you'll all be flat on the floor and I won't be able to CPR the group. There are 28 rules in the primary site histology or something like that, and you would turn me off after the second one. But these are all based on this blue book. Okay? This is the WHO Blue Book. This is what they look like. They all have the same look. There's one for breast. There's one for GYN. There's one for colorectal. There's one for hematopoietic and lymphoid. There's one for lung. So it has grown from that little pamphlet that I talked about earlier to this incredible set of documentation. And it is done with world experts. So the experts from the world get together and agree on, have a consensus for what the definitions for these conditions will be and what the characteristics, if they're looking at it microscopically, genetically, molecularly, whatever. But how did we get there? We started a long time ago trying to develop a world standard. In 1951 was the first clinical phenotyping for hematopoietic and lymphoid tumors. 1960, the Philadelphia chromosome was identified, but not the BCR-ABL1 part, the BCR-ABL1 only since 1990. Okay? And look at all these classifications. Rappaport, Keel, Lukeson Collins, revised Rappaport, FAB, French and British. You might even still see these in your path reports because some of your pathologists will still use them. But in 1982, leading up to 1994, the working formulation eventually became the real classification, and we were starting to get consensus that the world would use together. In 2001 was the first publication of the WHO consensus classification of tumors of hematopoietic and lymphoid tissues. And in 2008 was the fourth edition. So that's what we're basing it on. So a lot of changes in a short amount of time. That's why there's so many words, because they keep changing the words. So the WHO classification for 2008, you'll never be tested on this. This is just stuff that is important, but it gives you the background. Incorporates the morphology, because remember we started out looking at stuff under a microscope. So you look at the histologic features. Then we started looking at what point in the cell differentiation process is the abnormality occurring. So we started to recognize that they weren't mature cells that were becoming abnormal. Frequently they were immature cells. Then came along immunophenotyping, where we could find out if they were B cells or T cells. And then came the genotype features. And the clinical features have always been there, but now we know to look for specific clinical features that go with all this other combination. And the 2008 WHO classification takes all of that together and classifies the tumors. Oh, by the way, this is probably a Hodgkin lymphoma. Probably HIV related. They tend to present with really big masses in the neck, under the arm. That's a leukemia probably because of the bruising and the kind of wasting. So they're having weight loss. These are genetic alterations and aberrations, and then just some stains on the top. Just so you know what that stuff is. So the 2008 WHO classification grouped the myeloids and the lymphoids into two different groups. And again, the ICD-03 does not include a lot of these new codes and terms, so don't use it. What's in that WHO Blue Book is identical to what's in the database and in the manual. So if we're looking at myeloid neoplasms, the first group is the myeloproliferatives. So here we have not yet leukemia, but a proliferation of myeloid cells. Okay? These used to be called syndromes frequently, because they weren't considered full-blown leukemias yet. Then we have this new group with the PDG-FRA and PDG-FRB and FGFR1 abnormalities. And those are specific tests for specific conditions. They're new, so they put them in a group of their own. This group will probably grow as more and more testing is identified. And then this group of myeloproliferative, myelodysplastic. So we're going from making more cells to starting to make more abnormal cells. So the myelodysplastic, they're starting to be abnormal and look malignant. So it's not just making more normal cells, it's making more abnormal cells. And the myelodysplastic syndromes, which are frequently the ones that don't sound like leukemia, and then acute myeloid leukemia, which is a large group. But see, this is where you see all these genetic transformations is in those acute myeloids, because a lot of studies have been done there. And the last group here is acute leukemia of ambiguous lineage, which means the leukemia was so abnormal they couldn't quite figure out what it was. And either that or it was diagnosed in Podunk, Florida, and they didn't have the pathologist or the expertise to send it out or whatever, and the patient died or something. You know, there just wasn't enough information. So you saw that progression from proliferative to proliferative dysplastic to chronic, which was the myelodysplasias, MDSs, and then the acutes. So there was this progression. When we look at characteristics of myeloid neoplasms, we have about 45,000 new leukemia cases in the United States every year. And that includes all types. Most of them are AML. Those are in adults. A lot of CMLs. But if you were to look at this in terms of children, they would mostly be ALL. Okay? So they're not myeloid, they're lymphoid. There are no published data on myeloproliferative disorder occurrences, incidence, or mortality because we haven't started including them in our national reports yet. We've been reporting them, but we have really incomplete reporting. Remember I said a lot of times these could be diagnosed, treated, and never seen in a hospital? Until we have hematology and hematology oncology offices sending us cases, we'll miss them. So we can't report national data because it's not reliable yet. And again, some of these are clinical diagnoses, so you don't even get a path report. In a state like Florida, we see about 2,000 new leukemia cases a year. Chronic myeloid leukemias, we see about 250. AML, about 700. So that gives you some idea of what you would see in the U.S. and in a state. Risk factors, now remember we're talking about myeloids, okay? So the risk factors include ionizing radiation and exposure to cytotoxic chemotherapeutic agents. Those are the therapy-related diseases. Those are the only two that have been directly proven to be risk factor direct causative for the myeloids. Okay. The others are more, there's a relation, but we don't know how direct. Cigarette smoking is always on the list. Benzene exposure and exposure to other solvents and chemicals. Even for some people, exposure to gasoline, pumping their own gasoline. People who have familial bone marrow disorders can develop certain types of neoplasms from very simple exposures. They're just susceptible because their bone marrow is not working properly at the beginning of their life. So that a lot of research is done on those kids. One of the best things about kids and research, 90 to 95% of kids go on clinical trials that are diagnosed with any kind of cancer. And what percent for adults? 3 or 4? That will be changing, they say. But it's embarrassing, isn't it? I mean, you think about it. You know, why isn't more being done with adults? Signs and symptoms for myeloids: fatigue, paleness. Now, what would cause the paleness? Anemia. You wouldn't have that red blood cells. Weight loss, repeat infections because their immune system is compromised. Chronic fevers, not just a fever on Tuesday, you know, and one next month. This is a fever every day, every night. Easy bruising, nosebleeds, and other hemorrhages. Acute myeloid leukemia usually has a sudden onset because it's acute. CML, a lot of times, will progress very slowly. It might take 10 years for it to transform to acute phase. But frequently the CMLs will eventually get to acute. Some of them are really unpredictable in their progression or transformation. And they continue to try and research to see if the ones that progress or transform have certain genetic abnormalities that differentiate them from other, for example, polycythemia vera. Maybe there's 2 kinds of polycythemia vera that we don't know about yet. So when they start doing the workup for the myeloids, again, we talked about this. They do CBC, peripheral smear, bone marrow aspirate, or bone marrow biopsy. And what's the difference? The amount of tissue that's removed. Okay? A biopsy is going to give you less, just a few cells, or excuse me, an aspirate is going to give you a few cells, and a biopsy is usually a core. So they bore into the bone. They don't just stick a needle in. And then all these other tests follow to hone down on the diagnosis. And here's the basic disease course for these. And a lot of times we won't identify cases until they transform to acute, because they're not seen in the hospital till they have acute disease, and then they're in the ER. Okay? So MPD is No, P, proliferative. First proliferation, then dysplastic, then chronic, then acute. Okay? It goes in that stepwise progression. We've talked about a lot of these things already, like the diagnosis of inclusion or exclusion. And certain types, tend to stay in that chronic phase, and they can be unpredictable, which ones change. I like this one. This is a really nice graphic that shows this crossover. Here is the myeloproliferative. Then here's this mixed bag of myeloproliferative and myelodysplastic, and then myelodysplastic. Okay? And then they become chronic leukemias, then acute. The reason that I included this was to show you that a lot of these myeloproliferative and myelodysplastic syndromes, or neoplasms, actually not syndromes anymore, really, they don't have specific tests yet, because the research has really focused on more of the acute disease and the chronic disease, not the stuff that comes before. And but a lot of research is now being done in the myeloproliferatives and the myelodysplastic. The interrelationship of the myeloproliferatives is that about 10% of them become acute across the board. So this is kind of a framework, and this continues to grow and mature. Sorry about all the abbreviations, but it's just the way that you're getting used to this group right now, right? So remember BCR-ABL positive and CML with the Philadelphia chromosome? Those go together. And the BCR-ABL1 confirms this diagnosis. If they're not positive for BCR-ABL transformation, it's one of these other three. And if they can't figure out which one of the three, it's myeloproliferative NOS, or myelodysplastic NOS. This is a similar graph or a table to the one that I showed earlier that was simpler. See how I keep building? So I'm giving you more complex stuff as we go along. Polycythemia vera we keep talking about. And see, exon 12, we only have about 3% of positive, and that is one of the JAK2 tests. The other one is the V16 or V617F, and 92% of those are positive. So that's why it's diagnostic for polycythemia vera. We've already talked about this a little bit. I think that's a duplicate slide. This is just to show you that each one of these conditions has a set of criteria. And the pathologist and the clinician will go through this criteria because it is usually a combination of pathologic and laboratory testing plus clinical signs that will meet this criteria. Polycythemia is similar with major and minor criteria. Essential thrombocythemia also. So those groups have specific criteria that groups them into the different groups. Same thing with the myelodysplastic. There are two classification systems for myelodysplastic. All I'm going to really say is there are primary myelodysplastic syndromes and secondary myelodysplastic syndromes. So de novo is primary, arising from nothing. Okay? So the other causes for myelodysplasia, so myelodysplasia by itself is not reportable because myelodysplasia can be caused by smoking, radiation exposure, heavy metals, different exposures. It may eventually become myelodysplastic syndrome or chronic myeloid leukemia if they keep exposing to these different things. Okay? So those are the risks that lead to disease. Treatments are basically transfusions still. A lot of the clinical trials now are high-dose chemotherapy plus or minus stem cell transplant. So there's a lot of research being done there. They are trying to cure or at least minimize disease earlier in the disease process so they don't become acute at some point in time. And here's the drugs. Now, it's interesting to look at these drugs because they're old drugs, a lot of them. They've been around for a long time. So when the TKIs came around, the tyrosine kinase inhibitors, Gleevec, it was huge because they've been using these same drugs. They keep changing the dosing and the scheduling, you know, some on this day, some on that, trying to get the right mix. But there wasn't really a breakthrough in the drugs for a long time, not since like the 70s, 60s or 70s. CML is really known now as CML BCR ABL1 positive. And, you know, again, you're getting, it's so nice to look out and you're not zoning over when I start rattling off all this stuff now. So it's good. They used to call this chronic granulocytic leukemia. Now, why would they call it that years ago? Because under the microscope, they could see the granules in the and they called it granulocytic. So it was a description of what the cells look like under the microscope. The BCR-ABL1 is a genetic transformation, so it's much more specific. And then this tells you what the diagnostic workup includes and what have you. If a person tests BCR-ABL1 negative and they still call it CML, there's probably an error. Okay? It does rarely, I mean really rarely occur. And here, these are the characteristics of the chronic phase of myelogenous leukemia. They still use that term, granulocytosis. And then CML is very similar. I mean, we're talking about CML, and the early part of the the Philadelphia chromosome, you know, that was a breakthrough back in the 60s because they could clearly identify CML. But then they started finding that not everything that was Philadelphia chromosome positive was a CML. And that's when eventually they found the BCR-ABL1. Oh, here's a picture. So what happens here is on chromosome 9 and chromosome 22, this ABL part of it clips off. This BCR part clips off. So this is now missing that. And the Philadelphia chromosome is created by combining the BCR and ABL parts from two other chromosomes. That's why it's so clearly diagnostic, because you don't get this Philadelphia chromosome any other way. Okay, we've talked enough about this one. This is what it looks like as a fusion gene. It's called a fusion gene because the abnormalities fuse together, and then they start to reproduce. We already said that. Treatment options. Oh, this is important. This is basic concepts in treating leukemia. And it's becoming basic concepts in treating other diseases because as we learn more about certain solid tumors and other lymphoid tumors, we're looking at more of these diseases as being systemic at the beginning because there are malignant cells circulating all around. We stage them, you know, with our local, regional, you know, T1, et cetera. But the concepts of treatment options are so follow. You have an induction therapy. In solid tumors, it might be surgery. And then you have a reinduction therapy, which might be adjuvant chemo. But for our leukemias and lymphomas, induction therapy is chemo. And it might be some hormones. Reinduction occurs when they go back and retest to make sure that all the disease is gone. And if anything is left, they start chemo again. So they reinduce. So what they're trying to do is get a full remission. Once they get that full remission, they put the patient on consolidation therapy. Okay? Consolidation therapy is kind of a cleanup. The person is testing negative for disease. They think they've cleared it all out, but they want to consolidate it and sweep up any of the little remains. More and more often, you're seeing a bone marrow transplant or a stem cell transplant. And remember, we talked about the reason why. Because the only way to truly get rid of these diseases is to get rid of everything. And then maintenance therapy, if patients need it, to keep the disease away. There is treatment by phase. Chronic phase, obviously, would not get the same kind of treatment as an acute phase. And again, I talked to you about the accelerated phase. You don't really see that very often, but there are the criteria for that. And this is a funny statement where it says some patients progress directly from chronic to blastic without an intermediate accelerated phase. That's probably not true. There probably is an accelerated phase, but the patient coming in during that accelerated phase doesn't usually happen. It's just a rare thing. And some patients never progress. More definitions. Precursor neoplasms. That's kind of an interesting term, isn't it? I used to think precursor neoplasms meant it's this before it's that. But that's not true. What it has to do with is the genetic abnormality occurs in a precursor cell before it's mature. So that's what precursor means. So when you see pre-B acute leukemia, acute lymphoblastic leukemia, it's because it's a pre-B cell that's abnormal and proliferating. And AML treatment is aggressive. They need to control the bone marrow, or usually kill off the bone marrow, get all those cells out of there and dead. So it's a systemic disease because it's not just the bone marrow that's involved, it's all that circulating blood or lymph or both. So combination chemotherapy came about in the 1960s, I think, was the first time we started combining chemotherapies, believe it or not. So the world that you are coming into, a lot of things have changed. You know, I've been in this business for over 30 years. I have seen tremendous changes, and I've seen patients go from dying to living in many, many cases. So it's really an exciting business to stay in. So, and you'll see for these acute myeloid leukemia anti-neoplastic agents, very similar drugs, almost the same list as for the chronics. So they're treated with the same thing, but they might be treated with a higher dose, a greater dosing schedule, longer term. So there are different ways to play with that. So let's go to case number 3. Case number 3, we have a patient that presents with fatigue, irritability, and skin lesions. Well, the first two are me every day, okay? The skin lesions, no. Notice that everything was done in June. So when we're looking at dates, always keep in mind dates, and please remember to include in your text documentation dates. Really important. Text documentation just keeps getting more and more important. So the skin lesions were biopsied, and they showed lymphoblastic lymphoma in the skin, and they recommended a bone marrow biopsy. Now, why would they do that? Because lymphoblastic lymphoma doesn't usually start on the skin. So they want to also make sure that the patient is not a stage 4 at the beginning, because they would treat the patient differently. The bone marrow has all the characteristics of a pre-B-ALL, acute lymphoblastic leukemia. Immunophenotyping to confirm, which was positive for CD20, 29, and 22. Remember, the CDs are with the lymph stuff. So, same progression. Clinical with the H&P, biopsy, and then immunophenotyping, and then flow cytometry. So we're trying to hone down in that diagnosis the best that we can. So we've confirmed that this is a pre-B-ALL. How do we code the primary site? Is this a multiple primary? Is it a lymphoblastic lymphoma and a pre-B-ALL? No. Okay. All of them were in the same month. So, okay. And the primary site Okay, we're going back to the database. All I put in was pre. That's all I needed to do. But if I would have put in B cell, I would have gotten a whole bunch of stuff. I have it right on top, except there's a problem, isn't there? Obsolete, C code 9811. Code 9811 is not in your ICDO. So this is how I know when registrars aren't using the hematopoietic database. They use this outdated code because it's very direct. You don't even have to go look it up. You can just code it right there, C9811. But we do really want to look at it. Why? We want to make sure that the primary site we got right. And we want to see if there's anything else in the characteristics that are in this database that might waffle on the diagnosis, right? So let's go to 9811. There we go. Okay. So here it's reportable. Oh, there we go. Primary site. See abstract or notes. Module 7. We already looked at that, didn't we? Module 7 said code to the site of origin, wherever the primary site is. Most of the lymphomas do that. So what was our site of origin? And what else was positive? So which one do you pick? You pick the bone marrow because it's not necessarily the first biopsy. But remember, we're dealing with the leukemia, so we're making sure that leukemias go to the bone marrow. Okay? And that is described down here in the abstractor notes that help you determine what the primary site is. Also in pH 8 and pH 10 in Module 3. So let's go to Module 3, pH 9. See, I can't read. Okay, Module 3. Now remember, from the table of contents, you can just click on Module 3 and it takes you right there. You don't have to do all the scrolling stuff. Okay, Module 3, and we had which ones? Okay, the first thing you need to do when you look at your module is make sure that 9811's in there, and it is, right? Okay, there are a couple notes there you might want to read. So we're looking at pH 9. Code the primary site to bone marrow. Whoop, there we go. Okay. When the only involved site is bone marrow. Oh, but we have skin involved too, don't we? Okay, so let's look at the next one. Did it say 10? Yes. Code the primary site to the site of origin. Okay, so it doesn't really tell you if it should be bone marrow or skin, does it? Because it doesn't matter. Either one is correct. Okay? If I were doing the case, I would code it to bone marrow. The difference is very simple in that it will change your staging a little bit. But it's going to be stage 4 no matter what, because there's bone marrow involvement. Okay? And we're going to talk about staging at the very end. So we have our primary site. We have our histology. Is there anything else we want to look at here? Oh, look at this. Clonal stuff. Immunophenotype. Here are all these CD4 things, or CD10 plus and all that kind of stuff. Remember we had on our example? What do we have? 20, 29, and 22. Well, there's a 22. Well, we don't have 29 or the other one, but the 22. So we do have an immunophenotype that confirms the diagnosis. So we can use that diagnostic confirmation of 3 because we have a positive immunophenotype that confirmed the diagnosis of pre-B ALL. See how it's all coming together? What else can we look at here? Treatments. What would this person probably get? The pre-B ALLs are pretty aggressive in kids, so they're probably going to get chemo and a stem cell transplant or a bone marrow transplant. They'll treat it pretty aggressively. It's fairly common in kids, and they really hit them hard. These are same primaries, remember that? And I think that's enough for that one. We have one primary. It's bone marrow, which is what I would have preferred also. And it's 9811 with a diagnostic confirmation of 3. Okay, that's the myeloid neoplasms. Lymphoid neoplasms, remember we're talking about B cells, T cells, NK cells, that's about it. So when we look at the WHO classification, we have precursor lymphoid neoplasms, which are, see all those rearrangements there? The mature B-cell neoplasms, which is most of what you'll see, including the plasmacytomas and the plasma cell myelomas. Those are mature B-cell neoplasms. And they continue on here. And then the T-cell and NK cell, the Hodgkin lymphoma, and then the other two groups, which we've already talked about a little bit. Characteristics, we have quite a fewer lymphoid neoplasms, lymphomas, than myeloid neoplasms. That is increasing, continues to increase, and most likely related to viral exposures. Developing countries have higher incidences of some of these lymphoid diseases because some of these viruses are endemic, and so they're chronic exposure and lifetime exposure to some of these. EBV-related Hodgkin's disease, EBV-related Hodgkin's disease in Africa is horrific. People present with far advanced disease that is rapidly aggressive, and usually they're beyond treatment. Frequently, and then some of the pictures are, I mean, huge tumors and things. So, but when we look at a state like Florida, we see about 5,000 new lymphomas a year. So you'll see them, you'll do them. Causes and risk factors, again, genetic abnormalities from birth or as you grow. People think genetic abnormalities, you have to be born with them. Not true. Genetic abnormalities can occur as a result of those viral exposures, chemical exposures, air pollution, all kinds of different stuff. So here we have a lot of those already. Oh, and some of these cancer predisposition syndromes that I hadn't talked about. Down syndrome, there are some conditions related to Down syndrome. Lee Fraumini, who is a great researcher at NCI, neurofibromatosis, and Gorlin syndrome. And all of these exposures affect the immune system. Signs and symptoms, frequently you'll see enlarged lymph nodes in the neck, in the axilla or armpit, or in the groin. And these patients have either A, no symptoms, or B, symptoms, like weight loss greater than 10% of your body weight, night sweats, and these are night sweats where person wakes up in the middle of the night and you have to change the sheets. I mean, they're soaking night sweats. And they have them over and over again. Fevers, chronic fevers. They can be low-grade fevers, but they're always present. Pruritus, which is itching, skin itching, or shortness of breath. Why would you have shortness of breath? Because those lymph nodes could be impacting your lungs and restricting the airflow. You could have disease in different areas, so you could have shortness of breath for a lot of different reasons. The workup here again, we talked about this, lymph node biopsy or an extranodal site biopsy, and then the imaging usually will come along with the bone marrow aspirate. In order to do complete lymphoma staging, you must have a bone marrow, a PET scan, and a biopsy at a minimum. And then these other studies will clearly define what type of lymphoma it is. Remember the lymph node chains and organs? In Appendix C of the manual, you have all those nodal areas. This is just a nice little a diagram. But here is Appendix C again. So remember that Appendix C is there. It's a really great reference for solid tumors and liquid tumors. Now look at this. Here we have extralymphatic lymphomas. Now, what's extralymphatic? Outside the lymphatic system. So what's Waldeyer's ring doing in there? What is Waldeyer's ring? You have your tonsils and then behind Waldeyer's ring. Now, why do you have so much lymphatic tissue in your head and neck? And what about those Peyer's patches in your small intestines? Because when you're eating and breathing, you're constantly exposing your body to all kinds of stuff, viruses, chemicals, bacteria, and you need those filters to start working as soon as something goes in your mouth or your nose, and that's why your tonsils are there, and the Waldeyer's ring is the second thing, And then they go down in your stomach. A lot of times it's an extra lymphatic site, because it is very active in immune function, because it's digesting food and clearing out all that bad stuff. So nose and sinuses, again, breathing, that doesn't have a lymphatic stuff going up there. It all goes down your throat. So, and then for the nodals and the extranodals, these are the different types of lymphomas. So different types of lymphomas will arise in the extranodal sites than in the nodal sites. And the reason that I had these printed at 2 slides per page was so you could read them when you go home. If I tried to do them 3 per page, y'all would have been complaining. And I couldn't do 1 per page because it would have been 200 pages. So case number 2, we're going to be able to start getting through these cases pretty quickly now, aren't we? Because we know how to use all the materials, right? So I'm going to let you guys work on case number 2. I'll give you 5 minutes. Should be plenty of time. And you can cheat too and look at the answers and do it backwards if you want to. Because if you can back into it, you'll also reaffirm the logic. Okay. I know I didn't give you a full 5 minutes. But let's go ahead and take a look. And we have a H&P that shows that the patient was diagnosed with follicular lymphoma of the tonsil in 2009. A tonsillectomy and an adenoidectomy was performed. Now remember, the tonsils are a lymphatic site. FISH showed BCL2 gene rearrangements. Patient was disease-free since 2009, and now they have a lesion in their duodenum. It says lymphoma large B cell. And then the flow cytometry called it a diffuse large B cell lymphoma. So I hit you with a hard one. I didn't mean to, I'm sorry. But this is a fairly common occurrence where follicular lymphoma and DLBCL, diffuse large B-cell lymphoma, occur in tandem. When they occur together or when they occur separately, it can make a difference between 1 primary and 2. So when we look at the database, put in DLBCL, and DLBCL is a pretty interesting little condition, but it has a lot of references to these rules and modules. And there's a reference to this multiple primary rule, M5, which we haven't really talked about, but that tells you is it 1 primary or 2, and it depends on the timing of the diagnosis. And then these tell you how to code the histology. So what we're going to do next is look at the MP rule. So the multiple primary rules, you might think they're hidden because the primary site and histology rules are more prominent, but they are here right there, multiple primary rules. And we want M5. So M5 says abstract a single primary when both follicular lymphoma and diffuse large B-cell lymphoma are simultaneously present in the same anatomic location. That's the only time you do it as 1 primary. Every other time you abstract them as 2. Okay? But a lot of times, the diffuse large B-cell is bigger. It shows up more, and it masks the follicular a lot of times. And when they treat the diffuse large B-cell, then the follicular appears. It was always there, but sometimes it doesn't show up until after they treat the DLBCL. So it's kind of a tricky one. That's probably the trickiest of all the lymphomas for figuring out what the histology and how many primaries it is. This is another case we'll go through quickly. A peripheral blood smear shows high lymphocytes, worrisome for malignancy. Bone marrow shows malignancy, but nothing really else. CT scan just shows an enlarged spleen. But the flow cytometry says pre-BALL and the patient started chemo. So we've already looked at one like this, right? So the primary site is going to be bone marrow. That's where they got the cells for the flow cytometry. and it's going to be a pre-B ALL 9811. Okay. Quickly, let's see. We're going to go through the last 40 slides kind of quickly so we can get done. Okay? What is reportable and how you do case finding is an important part of your task, okay? Case finding can be difficult. There are ICD-9 and ICD-10-CM codes for these particular conditions, but when you look at some of these codes, it includes a lot of not malignant conditions. So you might be reviewing records that got pulled, or you look at your EMRs, because of the code that aren't malignancies, okay? Because some of them are still in ICD-9, and unfortunately still in ICD-10, are under syndromes instead of malignant, okay? So that's why they are kind of goofy, and they have extra stuff in them. These should appear in any of your case-finding lists, but I just want to warn you that when you start reviewing cases, not all of them will fit the criteria to be reported. This is included because these are fairly new codes. In ICD-03, they have a behavior of /1, but you're not going to use your ICD-03, right? Because in the hematopoietic database, they're all malignant /3. We talked about the manual, and you saw me navigate through it, clicking on the different things and bookmarks. You can open this window on the side also to look at your bookmarks, to cruise through them a little more quickly. In the first part, there are reportability instructions, but this is to show you that there are links within the manual that will take you right to an appendix or take you somewhere else. There are also external links that will take you to a website if your computer or your hospital will let you go to external websites. So all you have to do is click on them and it'll take you there. Like this one just took me to the NCI's page. The flow charts. Currently, the multiple primary histology coding rules have 3 formats: text, flowchart, and matrix, but not for much longer. Pretty soon, they're only going to be text. They're doing away with the flowcharts. They're doing away with the matrix. You have to ask Seer. It's easier to teach. It's easier to reference. Unfortunately, I don't use the text ones. I use the flowcharts. So, and when we developed those rules, we first developed them writing text, and then we did the matrix, the tables, and we found errors in the text. Things weren't in the right order. And then when we did the flowcharts, we found more logic errors. Things weren't in the right order. So I asked the SEER folks the other day if they planned on doing that as part of their testing, and they said, we didn't plan on it, but maybe we should. Because, that was part of our learning process. We thought we had it right just writing the text rules, but we had things that went to dead ends and things that loop back around so you didn't ever get an answer, things like that. So we tried to fix it. You can highlight stuff by activating. If you go to advanced when you're in a PDF, you can click down this menu and you can click highlight text or add notes. So you can add notes or highlight text in your personal copy. It won't copy over all of it if you get a new version, but it will copy over some of it. If they're on the same page, that's the biggest problem. You can personalize your viewing by making things bigger or smaller. This little thing right here will make things bigger or smaller for you. So that's navigation through the manual. Navigating the rules. The rule basics are you got to answer 5 questions. Is the condition reportable? That's a big question, right? How many cases do I abstract? And for most of these, it's going to be 1. 95% of these, it's going to be 1. How do I code the primary site? And you're going to use what for that? The manual and the database both together, right? And how do I code the histology? You're going to use both the manual and the database. And how do I code the grade? There's a table in the rules for coding grade that tells you which histologies require which grade. Okay? And there's also edits in place. So if you code it wrong, you'll get an edit and you'll fix it. And you'll learn. New registrars learn a lot from failing edits. Yeah. And remember, you don't change the data to pass the edit. You check the data to make sure it's right. Yeah, okay. And then there's kind of an order to this. You know, you go back and forth. We've seen how we work it. Go back and forth with the database and the manual a little bit. That was kind of hard to teach people in the first place, which it was like a chicken and the egg thing. You know, what do you do first? So we really ask people now to do their searches on the database first, and then look at the database and see if it refers you back to the rules. This is pretty much soon going to be not applicable. The M rules, there are only 13 of them, so they're really simple. So if you see a reference to an M rule, please go there. And if you see a reference to a pH rule, please go there. This is an example. I'm not going to go through all these. I said 29. There are 49 pH rules, which is why they're in modules. So you go to the module that you need to go to. The database will tell you what module to go to so you can navigate to the right place. Otherwise, 49, how am I going to find the rule I need, right? Or who's going to read it? I wouldn't. So we had to navigate it. And then each of the modules has this section at the top, and it tells you what's in that module. There will be some notes, and it also tells you what histologies, what codes are covered in that module. So you should always confirm, if you're using a pH rule, that the histology is in your list. The grade of tumor are the G rules, and I just refer you to those because you will never know them by heart. These are lists of tables. This is in a matrix, but it's also in the text, where they just have a list of codes. Those are all coded to T cell. There's a whole long list that's coded to B cell. There's another list that's coded to NK cell. The glossary, which I told you about, don't forget that it's there. If you see words that you don't know, check the glossary. And the appendices we've already gone through. We're not going to look at that case right now because I want to get to staging, and I don't want to run out of time. For collaborative stage, we have 5 staging systems, or 5 staging schema, excuse me. And remember, collaborative stage data collection is not a staging system. It is a coding system. TNM is a staging system. Summary stage is a staging system. This just is a coding system, collaborative stage. So there's a schema for Hematopoietic. Why do we call it Hematopoietic? Because these used to all be called reticuloendothelial neoplasms. And you think hematopoietic is hard to say. There are 3 direct lymphoma schema. 1 for very rare ocular adnexal lymphomas, which I've seen 2 in my career. Mycosis fungoides, which is a T-cell lymphoma of the skin, has its own schema, and the regular lymphomas. And then the myeloma plasma cell disorder used to be up here in the Hematopoietic until the new classification came out, and that pulled it out into the lymphomas, so now it has its own schema. So there are really 4 lymphoma schemas if you include the plasma cells. When we look at solid tumor staging, this is summary stage. In situ, localized, regional, distant. Okay? In solid tumor staging, there's a progression of disease from the organ of origin out. Leukemia staging, 97 or 8% of your cases will be systemic. Very, very rarely you will see one of these other conditions. Occasionally you'll see a myeloid sarcoma, but if you see a chloroma, a myeloid sarcoma, remember we started early talking about those, the green tumors? look for myeloid leukemia also. Because if there's myeloid sarcoma and myeloid leukemia, you code the leukemia, because it's everywhere. And the Hematopoietic schema has a gazillion codes for what's included there. Oh, that's only the first page of them. I didn't include the other. There are 2 more pages of just numbers. So for lymphoma staging, remember we said the patient has to have a biopsy and a PET scan, probably. This is kind of a graphic of what a PET scan might look like. And a bone marrow biopsy. And the reason, and it used to be that we required 4 PET scans, age showing again, you had to have a CT scan above the diaphragm and below the diaphragm. So now you have a PET scan that includes above and below. Because what we're looking at is one nodal area is localized, or stage 1. Or if just your tonsils, it's extranodal. It's stage 1E, extranodal. Just your tonsils are involved. A stage 2 has 2 nodal areas involved. And it can be both sides of your neck or both sides of your armpits, because each one of them is a separate nodal area because it drains a separate part of the body. Okay? And then we look at above and below the diaphragm. If you have disease above and below the diaphragm, it's stage 3. And stage 4 is above or below with some other organ or bone marrow involvement. And it's pretty simple staging when you get down to it, especially now that they always get a PET scan. Before, you would have to find the CAT scans, you would have to find the bone marrow biopsy, and a lot of times they wouldn't even do it. They would just treat the patient. So it's become a lot easier with PET scanning. Here is the lymphoma staging schema. 1, 2, 3, 4. These are the words that go with the pictures. And these are designations that are applicable to every stage. So a stage 1A is localized with no symptoms. A stage 1B is localized with symptoms. Okay? A stage 1E is localized extranodal, like this is a stomach lymphoma, but it's just in the stomach. And a stage 1S means that the spleen is involved. You don't see that designation used very often, yes. But you will see A, B, and E used all the time. The lymphoma schema involves those codes, and it's basic staging, but there are a lot of 9s. And your software should default to that. There's a site-specific factor for HIV/AIDS positivity, for A or B symptoms. For the IPI and FLIPI, these are prognostic indices that you may or may not see in your chart. I see them rarely, but some people will see them frequently. And then nothing else. Plasma cell neoplasm staging is evolving. Okay? I predict that in the next 5 years, we will not be just abstracting plasmacytomas and plasma cell myelomas, but we'll also be abstracting MGUS, monoclonal gammopathy of unknown significance, because a high percentage of those become progressive disease. And these light chain diseases will probably also come into our reporting at some point in time. So it's still evolving. And I'm really interested in the plasma cell neoplasms, because when I worked at the Southwest Oncology Group, SWOG, I used to write investigational protocols for myeloma. It include double bone marrow transplants and all kinds of cool stuff that didn't work, by the way. But in plasma cell neoplasms, treatment has recently been improved with some new drugs that were orphan drugs, like thalidomide, and some of the derivatives of thalidomide. So there are new treatments now. And this is the Duryea-Salmon staging system. And I think there's a site-specific factor for Duryea-Salmon. Duryea and Salmon were like pioneers of plasma cell myeloma research, including the plasma cell dyscrasias, the MGUS, and plasmacytoma and plasma cell myeloma. They're really interesting people, both of them. One's still alive. I don't think both of them are. But this is the basic staging system that's still used today. And this is the new myeloma staging schema. It's only been out a couple of years. And it's very similar to the lymphoma, but it does have the Duryea-Salmon staging and multiple myeloma terminology. And we seem to have made it to the end.